bacillus. And so the approximately like 10.8 million people get infected, around 10 million get infected each year. And it's a leading cause of death in patients with HIV. And as you know, the TB burden in the world is concentrated more in like 8 countries, and our neighboring India, it has the about 25% of world TB burden. So that is, of course, will impact whatever the control measures we want to apply in our country also, because we are so close. So what is the situation in Sri Lanka? At the moment, Sri Lanka is a low burden country, and actually second lowest in the region, and it's around uh, 29 cases per 100,000. Uh, and also mortality rate is also little bit on the high side. It's close to, at the moment, it's close to 10%. So that is a concerning factor regarding tuberculosis in Sri Lanka. When we discuss tuberculosis, this is also important because we want to eradicate TB or eliminate TB from the world, because it was yeah, like if you think about a patient with tuberculosis, if you get tuberculosis, you will have to get treatment for so long, and also you will if it is diagnosis is delayed, the patient will become significantly disabled and maybe even become like what you call as a respiratory cripple if you have pulmonary TB, advanced pulmonary TB, because they will lose whatever their income generating activities or the ability. And also they will whatever the cost for traveling for treatment and all, that will cause them to go on like further into poverty there. So these issues are there, so it is very important, and there are so many deaths. So we want to eradicate TB, and WHO has this NTB goals. So this is an important thing you have to remember, because all of us need to contribute as much as we can for the diagnosis and proper treatment, and try to reduce the burden of tuberculosis in Sri Lanka. So these milestones are there. These targets are there, NTB targets. So there are 3 targets: reduction in number of TB deaths. So we want to compare it with 2015 figures, and compared to that, we want to come down to 95% reduction in TB deaths by 2035, and also TB incidence rate we want to bring down 90%, and TB affected families facing whatever the catastrophic cost due to TB, that also we want to minimize and make it zero. So we will discuss in our latent TB presentation where we are at the moment, but we are nowhere near these targets still. But the efforts continues. So it's also important, because I think most of you are aware, but if you don't know, this is important to know, because in Sri Lanka, management of TB is very structured. Once you identify a patient, that patient's management is very much structured, and it happens most of the time without problems. So that is because we have this National Program for Tuberculosis Control and Chest Diseases, what we call as NPTCCD. So the NPCCD has published so many guidelines. Regarding all the things we are going to discuss regarding pulmonary TB, extrapulmonary TB, latent TB, and also HIV TB and multi-drug resistant TB. So there are guidelines available, and most of the guidelines are available in the web. So if you need any further information, more information, you can reach those through this NPTCCD website. And so I said we want to control TB. So at one hand, we want to identify more and more TB patients, and also we want to manage the TB already identified patients properly, and also uh, under the identification now this contact screening and high risk group screening also comes. So if you got like central level under the DGHS, we have the director NPCCD, and we have the central unit and the chest clinic, Colombo chest clinic and chest clinic Gampaha also are director NPCCD, and the National TB Reference Laboratory, that is called NTRL, that is also in Wathsala hospital premises, but it is a separate institution directly under the NPCCD, where all these culture facilities, advanced testing is available, and also central drug stores. Then regional level, under the professional directors of health services and RDHS, we have district TB control officer, who is at the district chest clinic. So yeah, and under him there are public health inspectors and many staff members that are involved in controlling TB. So, because the drugs for TB are not available, they are not available in the private sector, because otherwise it will cause ill use and lead to drug resistance. So all the drugs are controlled and given only through the chest clinic and main hospital. There is a short supply. So all those patients, if you diagnose a TB patient, or if you think the patient can be having TB but need further evaluation, easily you can refer to the district chest clinic or the nearest hospital as well, if there's no nearby chest clinic. So far. Okay, so if you then we'll proceed. So by definition, these are basic things most of you will know, but for the completeness sake, I have added these, so I will just go through them. You know, by tuberculosis is an infectious disease, mainly affecting the lungs, and it can affect all the other organs. What we say is, except hair and nail, where there are dead tissues, all the other organs can get affected by TB. And you know, tuberculosis is caused by Mycobacterium tuberculosis complex. And what are the ones that are this complex? What are the organisms or the species that belongs? M. tuberculosis is the most important one. The other two most commonly human ones are the Mycobacterium africanum and Mycobacterium cannati. And there are 8 species of mycobacteria that comes under this MTB complex. So other bacteria are most commonly as in other animals like cattle and so on. Then, as you know, this caused by the acid fast bacilli, and usually they are slow growing, obligate aerobes, and they have virulence factors. They are cell envelope as well as they have this lipoarabinaman that is in the cell wall that induces cytokines. So LAM is one test we can use for test for TB as well, assessment of LAM in urine, especially in HIV patients. Then transmission exclusively airborne, and from patients with active pulmonary TB, this is a transmission, how the transmission happens. So extrapulmonary TB generally are not infectious, but mind you, if you consider like empyema, TB empyema, if you open into that cavity, thoracic cavity, maybe during surgery and all, then those conditions can be highly infectious. But generally, it is through the pulmonary TB that you get the transmission from one person to the other. So, as you know, first step in inhalation is you inhale the aerosol droplets, and they are deposited in the lungs. And possibilities are what? One thing is you might be able to clear the bacteria totally. That happens very, very rarely. Then the other one is it can go on to develop the give the your disease with all the symptoms. So that is called tuberculosis disease. You will have signs and symptoms of TB. So this was earlier called active TB. Different ways we call no active TB and so on. But the proper term is tuberculosis disease. Then the other thing is tuberculosis infection. That is what happens. Your bacteria gets into your body, but it is contained inside your body. They are not all dead, but the few are remaining dormant. But generally, they are contained in granulomas, and uh, they are not having any these people will not have any signs and symptoms of tuberculosis disease. The bacilli are contained inside, but if you test, you might detect evidence of past tuberculosis infection like Mantu positivity. So that is what is called a tuberculosis infection or latent tuberculosis. So I hope all these are very clear to you. Then this is important. So just go through what happens. So you initially primary tuberculosis generally happens in children, but it can happen in adult. So when you are exposed to TB, generally it's through the lungs, but in rare cases it can be through the gut as well. Generally what will happen is there's a tubercle bacilli will make the gons focus, usually in the lower lobes peripherally, and draining lymph nodes will be enlarged. So that is called the primary complex or gons complex. So most of the time, these are contained like this. So nothing happens. They will have developed the features of immunity. So more than 90%, they will heal and remain. So they will have the evidence of Manto positivity. And in less than 10% of cases, they can progress, especially if they are having any malnutrition or immunodeficiency. They can have either progressive lung disease or this from the initial infection. It can spread to bloodstream, and it can disseminate throughout the body, and sometimes, especially in children, it can lead to disseminated TB and miliary tuberculosis. But most of the time, even when it is spread, most of the time in the end organs, they will be dormant most of the time. But in some patients who are immunocompromised, they can develop miliary tuberculosis. And what happens to patients who have initially healed? Then they can get a reactivation of tuberculosis uh, due to mainly their immunity going down, or even uh, in patients there's a lifetime risk. Even without any immunocompromised state, there's a lifetime risk of 10% being developing into active TB. So what happens, it can in the lungs or any other organ, and can progress. So the other thing that is not mentioned, what is not mentioned here, so that is primary TB and post-primary TB. We can talk about post-primary TB. So primary TB happens when you are never exposed to TB, and then post-primary TB can happen by endogenous reactivation reactivation of whatever the dormant bacilli in your body, or exposing to somebody with uh, infectious TB, but you have already had some primary infection and the immunity. So those are the two case scenarios, reactivation here mentioned and the reinfection. Same thing will happen, and they develop their clinical features. So this is same thing I have explained. So spontaneous eradication is rare actually. Most of these things, there will be granuloma formation, and the body will try to contain it with some destruction. So that is why you see some patients with healed TB evidence but never been treated before with anti-TB. Uh, So, as I said, latent infection, lifetime risk of reactivation is 5 to 10%, and immunosuppression is a definite risk factor for reactivation, like HIV, CKD, diabetes, steroid use, lymphoma, advanced age, smoking. We'll discuss this later in detail. So, what happens when you get the primary infection first time? Most of the time, uh, they are asymptomatic, but you can develop in 10%, like you can develop symptomatic disease. And sometimes you will develop fever, sometimes pleuritic chest pain with effusion, and also maybe pharyngitis, this pectining conjunctivitis. So some immune manifestations to the initial exposure to tuberculosis bacilli also can happen. So reactivation of TB, it's most commonly in the upper lobes and superior segments of the lower lobe. That is thought to be because of the increased oxygenation and poor lymphatic drainage. And symptom onset is gradual onset, low grade fever, night sweat, cough more than 2 weeks, and loss of weight, loss of appetite, hemoptysis. And sometimes they can get, this is important, because sometimes they can, if they are having infectious pulmonary TB, when they cough out, that bacilli and the infection can affect their throat, and sometimes they can present with laryngitis like symptoms, hoarseness and all. So those patients also very important too. If the other constitutional symptoms are there, you have to screen for TB before going into like doing laryngoscopy and all, because that those are very infectious states. So as here, these are the high risk groups we consider for reactivation of TB. First one is close contacts of TB patients, because after exposure, first 2 years are
Pardon
the,
me, madam. Pardon me,
sorry,
madam. Madam, there is a
yeah.
message popped up from your screen at the bottom. Can you just hide that message?
Okay,
It,
hide. Okay,
ah,
sorry. Yeah,
Thank you
okay.
very much, madam.
All right. Okay. All right. Sorry for that. So, what are the high risk groups? As we discussed, the whatever the immunosuppressive conditions, but also close contacts of TB patients. It can be household contacts or other close contacts. We'll discuss this in detail in the latent TB part. Why is this? Because the first, when you are infected with TB bacilli, first 2 years, highest risk of being getting active TB disease. So that is why we now try to screen all the close contacts of TB patients, pulmonary TB patients, because they are at the highest risk of getting reactivation. And also, as I said earlier, patient living with HIV, elderly patients, malnourished patients, patients with diabetes, and also immunocompromised patients, and patients on CKD or maybe on anti-cancer treatment, transplant patients, uh, those are at high risk. Also, people living in high risk environment, that is also because they are most likely to get exposed to TB more, as well as most likely to have a recent TB exposure. And prison inmates, drug addicts, and healthcare workers, because their exposure is high, and also silica dust exposure, because silica induce whatever the lung damage can predispose to TB reactivation. So as I said earlier, I have put active TB, but actually that is not the correct word. It is the tuberculosis disease. Okay, so tuberculosis disease and the latent TB, or the tuberculosis infection. So active TB can be, as we know, it can be pulmonary, that is in the lungs, or extrapulmonary, including pleural effusion. Pleural effusion also comes as extrapulmonary. Those are the divisions. This is the same thing I told. Recently infected patients are at higher risk, like close contacts, immigrants, children less than 5 years, and also in situations where there's high risk of transmission. So those are because of they are most likely to be recently infected with TB bacteria, and also the other medical conditions, like the children, they are they have a weaker immunity than us, and the same thing we have told earlier. Now, now we want to now we have some background knowledge. So now I am going to discuss regarding the TB diagnostics. Uh, so what are the diagnostic methods you commonly use? Can someone answer, so that it will be more interactive and probably no postprandial like symptoms, because otherwise I am just talking. Can anyone answer? So what are the tests if somebody is having this? We all know there are four cardinal symptoms. So anybody with the for pulmonary TB mainly, cough more than 2 weeks, fever, low grade fever, nocturnal, night sweats, loss of, constitutional symptoms like loss of appetite, loss of weight. In addition, there might be hemoptysis. So those things are there, and maybe contact history is also there. So what are the tests you will arrange?
Sputum AFB.
Full blood count, ESR, chest X-ray, and sputum AFB.
AFB.
Yeah, very good. So all those things are important. So if you have one test, only one test you
Sputum
can
gene
know.
Sputum AFB.
Gene expert.
expert.
Sputum AFB, 3 samples.
Okay, so different ideas. So let's say if you want to screen this patient, the pulmonary TB, we are thinking about pulmonary TB. I know that let's leave out gene expert, because that is like a little bit costly and will most likely will not do. So the what the guidelines say is, first we have to and the best screening tool is what? Chest X-ray. Okay. So you can do a X-ray. All the other things are correct. You have to do the full blood count, ESR, because that will give the supportive evidence, and then sputum AFB. It's less sensitive but easily available test. So that is also good. And gene expert, correct, where it will give a lot of information. It is a more sensitive test, and also it will tell you about the whether there's drug resistance as well. So but what you have to remember is the best screening tool for pulmonary TB is chest X-ray. So once if there's any X-rays available, then sensitive one is to go for a gene expert, but because of the availability issues and all, and of course in the Sri Lankan context, we must do the AFB. What you have to remember is, this is in a way it is easy also. Sometimes when you get a patient with symptoms and signs suggestive of TB, people are very reluctant to go to give the sputum AFB. So if you, but it might be easier to convince them to get an X-ray. This is especially if you are in the private practice. So that you can probably convince them more and easily to see whether your lungs are okay. So you will get an X-ray. So then if there's any abnormality suggestive of X-ray, of course, then you can convince them more to go to a chest clinic and so on. So just remember, chest X-ray is the best screening tool. So these are the TB diagnostic test. So as you correctly said, sputum smear microscopy, and also rapid diagnostic test like expert MTB RIF, and also line probe assay is not commonly available to us, but it is available in NTRL. And other thing is TB culture, the gold standard, although it takes longer time. It is more sensitive, and chest X-ray. Maybe in certain cases, if all the others are negative, you might go for HRCT as well. Then other specific tests are there like ADA and all, where when they come, we'll discuss regarding them further. And what about MAN2? And also, you must have heard this interferon gamma release assays. What do you think? Does that tell you that patient, if the MAN2 is positive, does it mean what does it mean? Does it mean the patient is having active TB?
No.
No,
No,
it's not specific.
correct. Yeah, it just tells that you have been exposed. You have a type 4 immune reaction to tuberculous bacilli. Okay, so that is only thing that says. So it does not denote or differentiate between active or latent TB infection. It can happen in both. But in clinical context, when the other things are failing and there are chest X-ray abnormalities, all the sputum investigations are negative, then chest X-ray is suggestive of TB. Then if the MAN2 we do and it is positive, so there's evidence of past TB infection or current TB infection. So in that context, we sometimes use MAN2 as a aid for our diagnosis for active TB as well. But strictly speaking, it does not say whether it is an active or latent TB infection. Just says that patient is infected with TB bacilli at some point in his life. So that is what it says. So these are the common ones we use. Regarding MAN2 and the other test, interferon gamma release assays, we'll discuss in more detail in our latent TB part. So sputum microscopy, you can do a lot of ways. So what we commonly do is acid fast staining, Seal-Nielsen staining. Then you can do Orament staining as well, because if you look at the private sector reports, sometimes they have done the Orament staining as well. Then there's fluorescence microscopy. It is 10% more sensitive than the light microscopy. And also, so if you concentrate the sputums, you might get a higher smear positive rate. And also, now we generally do 3 sputums, or sometimes generally what we do is spot, early morning spot. That is the 3 sputums we do. Now the newer guidelines somehow has reduced it to even sputum 2 spots are okay. But if you have a really suspicious chest X-ray with cavity and all, cavitation and all, it's better to repeat the sputum, especially do early morning one. Sometimes when there's no sputum, as there's no sputum, sometimes we do a nebulized sputum after nebulization. So in these cases, sometimes the sputum becomes positive when you repeat the test. So because it's a very low cost investigations, of course, you can repeat. And if it becomes positive, it gives you some information regarding the patient management, one thing, and also regarding the prevention to spreading to other people and so on. So it's a very important test, especially in our type of country where there's like whatever the expenditure we can spend on the testing is not that great. So then this is the FB culture, the gold standard. You know that there's solid culture, that is a LJ medium, and also liquid culture. So what are the specimens we can do send for culturing? We can do all the sputums and also other biological specimens like fluids, aspirates, surgical specimens. So the important thing you have to remember is when you are requesting these tests, AFB also there's a special form. Better to use it because it gives information regarding the sputum quality and all. So wherever available, try to use this proper form. TB culture must be sent in the proper request form. And the important thing you have to remember is you have to put these samples, if they're surgical samples, so aspirates, or especially samples, biopsy specimens, you have to put in normal saline. If you put in formal saline, then you can't grow any mycobacteria or fungal. The testing cannot be done. So if you, let's say you take a lymph node and you want to send the sample, so you send part of it for histology, part for in normal saline for the TB culture and gene expert testing. Then we have gene expert. So all of us know about PCR technique. We have studied. So the gene expert is a PCR test, real-time PCR, and what you have to know is it gives evidence of whether the mycobacteria, tuberculosis present, and also information regarding rifampicin resistance. Generally, the test don't take much time, but because of the cartridge problems and the whatever the time taken to do this test, sometimes these are very much delayed because there's a backlog and so issues are there. But this is a very good test. And now we have the Gene Expert Ultra, which is even more sensitive than the Gene Expert that was available earlier. And I think the TB campaign is in the process of replacing all the Gene Expert with Gene Expert Ultra. So it is a extremely sensitive test. So it's a good test. Then also we have Gene Expert XDR. Sorry, not MDR, XDR. Okay. So that is for drug resistant tuberculosis. Then we have, you may have come across the term called TrueNet machines in some instances. What is TrueNet? It's also a similar PCR technique, but it seems that it's not sensitive as Gene Expert or Gene Expert Ultra, and it is recommended mainly to do the sputum pulmonary samples in this machine. That is the guideline given to us. So these are the highly sensitive tests, and the specific test. So very useful. So the current guidelines in the algorithms that are being developed, whatever what campaign wants to do is, like, all the patients who are coming with respiratory symptoms like presumptive TB symptoms, to get x-ray done. If there's x-ray changes, to straight away go for the Gene Expert. That is what they want to do, but the issue is they can't provide a continuous supply of Gene Expert cartridges. So uh, that is always a hurdle. So I will ask you one question. Then there's this patient who has respiratory symptoms, chest X-ray also. There are changes, mainly middle zones, some cavities and things are seen. And you do a sputum AFB and it is positive. And according to the guidelines, now current guidelines, all this even sputum AFB positive patients, we want to send the gene expert, because now the current guideline is divided into not sputum positive, sputum negative. We take it as drug sensitive TB, drug resistant TB. So to know about the drug sensitivity, we have to have a gene expert or rapid diagnostic test. So that is how we go. So this patient with sputum positive, AFB positive sample, we have sent the gene expert. It becomes negative. So what is the likely cause?
Sorry, again, I don't understand the question. Please, can we repeat, please, the question?
Yeah, the question is, you have a patient with cough and chest X-ray changes. You do a sputum smear and AFB, let's say 2 samples. And then you send for gene expert also, because you want to know about the drug resistance and confirmation. And that is MTB not detected. What are the possibilities?
What microbiota other than detected?
Yeah, correct. Very good. So the other issue is mycobacteria other than tuberculosis, what we call as MOT or non-TB mycobacteria. So that also can cause infections in the lungs, especially in this elderly females and all, with patients with bronchiectasis. So in those cases, you will see as fast bacilli, because those are also acid fast bacilli in the sputum. But when you do the gene expert, which only detects MTB complex, it will be negative. Okay, so that is something to remember. Then what specimens we can send for gene expert? You can send the sputum and other respiratory specimens like BAL, endotracheal aspirates and all, and pediatric TB cases, because most of the pediatric samples are very precious, so you can't have like repeat testing, do again and all that. So you don't generally, uh, you are not supposed to send for FB testing, but send for gene expert and TB culture. So especially gastric aspirates. uh, then extrapulmonary specimens like CSF,
What are the
other fluids.
indication for the TB culture? When we have to do the TB culture? Yeah.
TB culture at the moment, it's not needed. It's coming like going out of practice. Like gene expert, you must do. FB, you have to. You can do as initial test, but even if it is positive or negative, you have to do the gene expert. And depending on the gene expert results, you can go on for further management. Now, because now the culture, what is the information you will get? Culture, you will see whether it is a MTB growth or a MOT growth, and then they will do some drug sensitivity testing, isn't it? It will take some time. So that is what you get. It's a higher sensitivity, but what is recommended is now, if the gene expert is positive, you don't need to do a culture in all cases. But if they are not responding, you will arrange for a culture. But these are not in the guidelines yet. So what we have to do is, generally we send both gene expert and TB culture. If the sputums are negative, definitely you have to do, because even gene expert negative we have to do, because this is a more sensitive test, TB culture. That is a definite one. When the other microbiological tests are negative and you are still suspecting TB, you have to definitely do TB culture. There's no question about it. But if it is gene expert positive, whether you need to do the culture in the current context, still we do, but this huge burden of doing TB culture. So because our research labs are a little bit overwhelmed by doing unnecessary cultures. So we want to come down on it, but those guidelines, I don't think that our guidelines say like that. So it will be in the next guideline. So for you, I think we better to ask for both and TB culture and gene expert. I hope that answers your question. And the other for the gene expert result, testing, we can do the extrapulmonary samples. And what are the samples that are not usually recommended? One thing is blood stain specimen, like bone marrow aspirate. You can't do most of the time. And also urine is not recommended to. Sorry, there's some disturbance. Somebody's mic is on, is it? Can the host mute the mics? Can you please mute your mics, because other than if you are having question, because there's some disturbance in the background. Okay, so the generally earlier it was said the feces is also we shouldn't do gene expert. Now, of course, it is recommended to do gene expert in pediatric patients in feces, and there's a trial going on. And earlier pleural fluid also was not recommended, but now it is recommended to do even in not empyema, the other pleural effusions also. If you are suspecting TB, you can ask for gene expert, because then if it becomes it will confirm your diagnosis. Then this is also something you should know. When you are having risk factors for multi-drug resistant TB, those are these are the categories we are more concerned about: healthcare workers, prisoners, drug addicts, patient returning from abroad, and contacts of non-drug resistant TB, and patients who have followed. Just give me 1 minute. Okay, so those are the ones for high risk factors for multi-drug resistant TB. So as I said earlier, we now manage patients according to drug sensitivity. So whether the patient is having drug sensitive TB, or whether it is multi-drug resistant TB or extensively drug resistant TB. So that means we have to be guided by the gene expert, because there's no time to wait for the TB culture and the DST results to know the drug resistant in those patients. So this is the WHO recommended test gene expert as a initial testing. So
Gene expert is a blood test. Gene expert mean what is the test?
gene expert is what is called expert MTB RIF that we discussed regarding this PCR method, real-time PCR. So that is what is gene expert is actually the trade name. Proper word is expert MTB RIF, because RIF is because it says about rifampin resistance as well. And there's ultra gene expert ultra also, that is more sensitive than the earlier available gene expert also. Okay, so the same test. When I say gene expert, that is the trade name, but proper name is expert MTB RIF. Okay, so because we commonly use this term, I use it, but no, that is it's the same test. Okay. And then when we want to treat these patients, we want to uh, divide according to whether the bacterial is confirmed TB or clinically diagnosed TB. So this is also commonly used terms. You should know what does it mean. So bacteriologically confirmed TB is if the patients have AFB positivity, culture positivity, or WHO recommended rapid diagnostic test positivity, that is mainly gene expert or expert MTB RIF. So if those are positive, that means this patient is having definitely microbiologically proven TB. So in that case, we are more happy and confident, and we can easily hand over these patients to be followed up under chest clinic, because we know the diagnosis is correct. Then the other category that comes is the clinically diagnosed TB. That is when all the testing we do are negative, but there's evidence of active TB. Maybe it can be X-ray changes or other evidence of other organ involvement, maybe CNS TB. CSF analysis suggestive of CNS TB. So on, can be extrapulmonary sites. You suspect TB. The clinical features are suggestive of TB. Maybe the histology also shows granulomatous infection with caseation, but still you can't put them under bacteriologically confirmed TB, because there's no bacteriological confirmation unless if you get a histology specimen and same time you do either the TB culture or gene expert or AFB smears become positive on that specimen. So most of our cases are of extrapulmonary TB are mostly clinically diagnosed TB. It can be pulmonary and extrapulmonary TB, especially if you say somebody having cough, loss of weight, loss of appetite, chest X-ray changes, but all the MAN2 may be positive, but all the other negative, AFBs are negative, gene expert negative, cultures are TB culture negative. So we treat it as a clinically diagnosed TB, that is decided by the treating physician. These patients need more careful follow-up because we have not confirmed the diagnosis. So the other thing is, all of you know, generally because we use these drugs, rifampicin, isoniazid, we use throughout the regime, and we don't want to prevent the development of drug resistance. So if somebody is not compliant, and especially when they are having high bacilli load, if they are taking inadequate, if we are prescribed 3 drugs, they are taking 1 drug, or they are not taking it daily. So if those problems happen, the patient will likely to develop bacilli that are drug resistant. So the drug resistance bacilli will survive. So those things, to prevent that, we advice on directly observed treatment. So in the current context, earlier, there were dot centers in different institutions, and the patient had to go and drink in front of a person. In other countries, these telehealth measures are available where you use it like a smartphone device, and then some healthcare worker uh, observes. But in Sri Lanka now, it is more or less a family dot where we uh, give the responsibility to one of the close family member to
Madam,
see that.
madam, if we see
Yes.
ASB negative, culture negative, gene expert negative, then we can't tell the TB, no.
Yeah, that is what I said. That those are called clinically diagnosed TB. It's not microbiologically confirmed. Let's say if you take a biopsy lymph node, then histology shows caseous granulomatous necrosis, highly suggestive of TB, but the other tests are negative. And the MAN2 is also positive and shows the evidence of TB infection. So you treat as TB. It's a clinically diagnosed TB. It's not bacteriologically confirmed. And there are what we call as, earlier we said, smear negative TB. Because those days we didn't have this gene expert and all, no? So if the smears are negative, still the X-ray evidence of compatible with TB and the clinical history is compatible with TB, then we treat as earlier we called them smear negative TB, but now that term is no longer there. What we call is clinically diagnosed TB. So it's a clinical decision. It's a common thing, not uncommon. Especially EPTB, as I said, most of the cases we can't prove any of these microbiological tests will be negative. So we can't say it is a microbiologically confirmed TB, but still, especially on follow-up, most of the time we know that they are TB, because they are, when you start on anti-TB, their weight improves, appetite improves, whatever the symptoms goes off, ESR come down. So we know that is definitely TB, but there was no way we could find out. Sometimes we might be able, sometimes we do bronchoalveolar lavage also. Then even sputum gene expert is negative. Those kind of bronchoalveolar lavage gene expert might be positive, because those are more sensitive tests. So
If the
have
gene
to
expert
sometimes.
mildly, if gene expert mildly positive, are we taking as TB?
Yeah, that is like this. So gene expert is good for initial diagnosis, not good for follow-up. Okay, there's no point in doing a repeat gene expert in a already confirmed TB patient, because that is anyway, even few years time after TB treatment, it might still be positive. But what you are asking is
First time.
scanty, no?
Yeah, first time
Scan-
if it is mildly positive.
So if the mildly positive and never treated with TB, generally we do this test with clinical suspicion of TB, we order gene expert. We don't generally all order it in all patients, no. So in a patient with clinical suspicion of TB, we order gene expert. And then if it becomes positive and there's no past history of TB, or the past history of TB, then we take it as a true positive, even scanty positive, even in ultra. So there's a separate ultra guideline also, because gene expert, because is this query about whether the even one bacilli lying in your lung somewhere but not causing anything, can the ultra be positive? So that issue is there. But what the guidelines clearly says is, if it becomes positive, if the patient has no past history of TB and not treated for TB, you have to take it as a true positive. There are regarding these decisions, but generally for your purposes, it is taken even scanty positive.
Thank you.
Okay, you shouldn't ignore, because I have seen CSF sometimes gene expert positivity people have ignored, sometimes even in children. Somehow others saying this is bacterial meningitis, and then later on that TB culture becomes also positive. So these are dangerous things on clinical context alone, you ignoring positive test, because even legal implications are there. No? So the positive test, you have to be very careful. You should not ignore them. So dots is important. In Sri Lanka, it's mainly family dots. And then, as you know, drug sensitivity TB, we are giving 6 months of ATT, initially fixed drug combination, isoniazid, rifampicin.
Madam, if it is an severe immunocompromised patient,
Yeah.
then for false positive, no, we will getting the results. We have to treat as a TB, no, then?
Yeah, if the immunocompromised patient, all the more reason to treat TB, no? Because they might not develop any immune reactions. You will not see typical findings in chest X-ray. But if there's having any evidence of constitutional symptoms and all, then you have to take that as something serious. Yes.
Okay,
Yes.
thank you.
So FTC4, you know, the 4 anti-TB drugs, I am not going to tell. So the 4 drugs for 2 months, 2 drugs for 4 months. That is the 6 months course is the standard anti-TB regime. Few words regarding from this slide is from WHO guidelines. So the recommendation is the new patients with pulmonary TB should receive a regime containing 6 months of rifampicin. So what we give, strong recommendation. So this also applies to extrapulmonary TB, except for where we need longer regimes like central nervous system and bone and joint TB. And also we have to monitor for drug resistance surveillance also necessary. I have put this because in the near future there might be a shorter regime available for 4 months. I think the campaign is thinking about it, but at the moment it is 6 months of anti-TB is the standard treatment. So this is same thing, because fixed drug combinations are better. You know that this has been taught to us even from medical student days, because the pill burden and also missing out on certain drugs, patient omitting for specific drugs, so the emergence of drug resistance, all those can be avoided in fixed drug combination when the fixed drug combination is used. Sorry. So I have actually forgotten to put it, but I will tell you now. Earlier, we have the new patients and retreatment cases. Like if already treated patients become positive again with whatever the test we have done. Uh, uh, let's say patient with pulmonary TB, treatment completed and cured 2 years back, diabetic patient, and coming back in 2 years time with loss of appetite, loss of weight, hemoptysis. There are new X-ray changes of extensive TB, and the AFBs are positive, and let's say TB culture is also positive. This you have done the teen expert, the MTB is positive, but there's no drug resistance. So in that case, why we treated as a retreatment case earlier. We give 8 months of ATT, isn't it? We gave 3 months of FDC4 and FDC3 for 5 months. That is without pyrazinamide, other 3 drugs. So that practice is going out, and actually the TB campaign has issued a statement or a circular saying that not to do that. So all the patients who are proven to be drug sensitive TB, even if they are retreatment cases, we should treat for 6 months with 6 months of anti-TB drugs. So that is what that is how the things are evolving. All these things are evolving. I can't put it here because there's no, like, the guideline is still not published, but this is what we are practicing now. So tuberculosis, I think you need to know much about drug-resistant TB, but you should know that at least you should have an idea about the risk groups we have discussed, and also regarding what are the definitions. Okay, so the drug resistance can be mono drug resistance or polydrug resistance. So mono drug resistance is against drug, polydrug is more than one drug. So from the mono drug resistant TB, the important one is isoniazid resistant TB, what we call as HRTB. So in the drug resistance guidelines, there's a specific way of managing isoniazid resistant TB. Okay, so remember that. Then other monodrug resistance can be, rifampicin. We are taking it separately. We'll discuss it in a bit. Then the other important definition is the third one, multi-drug resistant TB. I think all of you know what is the definition of multi-drug TB. When the MTB strain is resistant to both isoniazid and rifampicin, it might be having with or without resistance to other drugs. So but what you have to remember is resistance to isoniazid and rifampicin. Then we have what is called the extensively drug resistance TB, XDR TB. So here the patient already has MDR, that means rifampicin and isoniazid is resistance is there. In addition, they are resistant to quinolone, like what we use for drug resistant TB, levofloxacin and moxifloxacin. So resistance to one of those, and one additional group A drug. That is because we have grouped the MDR drugs into group A, B, C, and so on. So in the group A are the most effective ones. So if they are also resistant to one other additional group A drug, then that is called the extended resistant TB. So this is either two drugs, either bedaquiline or linezolid at the moment. Then there's another condition called pre-XDR. That is, they have not still got the extensive drug resistance, but they have developed resistance to both rifampicin, isoniazid, and quinolones. So if they develop another resistance like to bedaquiline or linezolid, they will become XDR. So this is pre-XDR, XDR. And the other one is rifampicin resistant TB. Because I said this, although it looks like a monoresistant, but it is not. It can be either monoresistance or it can be included in MDR TB or extensively drug resistant TB. All those comes because if there's rifampicin resistance, it can be categorized as RRTB. What is importance? Because now you know gene expert or expert MTB RIF, the PCR test we discussed earlier, will tell you regarding the presence of MTB as well as whether there's the presence of rifampicin resistance. Okay, so that molecular test will give that information. And if there's rifampicin resistance, we take it as a surrogate of multi-drug resistance. And we manage these RRTB patients as multi-drug resistant TB because that is one of the most effective sterilizing drug to remove the bacteria from your body. So that is a serious condition. So remember rifampicin resistant TB, but you don't need to know about how to treat these patients. You have to always refer, and just one thing you can remember, because earlier MDR treatment regimes went on for like 1.5 years, sometimes 2 years. But now there are new treatment regimes that have been developed. Uh, 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 because they have developed new drugs. Actually, these drugs are developed mostly by donors and not by pharma. These are by researchers and by donation done by many institutions or people for TB uh, 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 medication development. So they have come up with some of the very good drugs like bedaquiline, protomanide, and so on. So those drugs have made it possible for us to have a very short regime of 6 months. That is called BPAL or BPAL-M. So just know that it's possible for a MDR TB patient to have a very short drug regime as well. So what can we do as healthcare workers? So, so this is the last slide of our first part. So all healthcare workers have to act as leaders towards elimination of TB, and you have to keep TB in your differential diagnosis, because most of you, I think, are general practitioner, having a general practice. So you will come across these patients who are having cough, prolonged cough, coming again and again with cough, and sometimes they might look like asthma also, but always better to screen for TB at least with the X-ray. Okay, they can be healthy looking, well to do. So those things will not rule out TB. And of course, if you are not having facilities or ability to investigate further, always refer to the district test clinic, or sometimes there are microscopy centers. If you want to get the FBs done, there are microscopy centers also. So try to get some information regarding what is available for you in the nearby area. And also we'll discuss regarding the latent TB treatment. So you have to know about the patients who are having this, are at high risk of TB reactivation. So whatever your diabetic patients, CKD patients, so elderly patients, so you have to keep them in your mind, and if necessary you can refer them for latent TB screening. And also patients in your care with a positive TB contact, so always you can encourage them to go to the chest clinic and get their screening done. And also we must minimize the stigma, because even if I get TB, I am scared to go to because I will also wonder what will happen to me, what will other people think about me. So that is what is the stigma still it is there in the community. So I will of course not think like that, but most of us will think like that, what will happen to me, who will they will shy away from me. So all the people are worried about the stigma associated with TB. But there are some people who are very enthusiastic, and they will tell why TB වෙන්න පුළුවන්ද අපි ටෙස්ට් කරලා බලමුද doctor. So there are so many other like that sort of patients are also who are educated. So it's your duty to educate and encourage and minimize the stigma. So that is how you can help. So from this part, if you have any questions, I am happy to answer.
Madam,
So far, is it
after
all
initiation
right?
treatment, Madam, just
Yeah.
one question. After initiation the
Yes.
treatment, how long they are infectious?
Generally, what we call is rapidly the infectiveness goes off, but at least like within 24 hours, their infectivity drops. But by 2 weeks, they are not, most of the time, not infectious. But what we say is, because we generally wait until initial phase. Intensive phase is over and then do the sputum. And if they are negative, we say you can go to work. So we have to be a little bit diplomatic, but know that the infectivity becomes very, very low after 2 weeks. So, but because of the other people's like worry and all, generally we keep them smear positive patients. We keep them 2 months of their work and all. And what you have to advise in the household is when they dispose their sputum, tin එකකට වගේ එකකට දාලා වලලන්න කියලා වගේ එහෙම කියන්න පුළුවන්. They have to safely discard their sputum initial period because that can be infectious, especially in smear positive patients. But smear negative patients with pulmonary TB also can be infectious. Okay, so you have to keep those in mind. Is that all right now? Shall we move to the next one? Because there's a lot to discuss. Is it all right with you? Or do you need a 5 minutes like break? Shall we proceed then? So extrapulmonary TB only slides. Okay, can you see? Can you see the new slides?
Can see, madam. Yeah. Extrapulmonary tuberculosis, principles of diagnosis and treatment.
Okay. So this is actually, this was lent by Dr. Manil Piris. I am very thankful for him for giving me these slides because I didn't have on extrapulmonary tuberculosis. So this is a brief discussion, brief presentation, but you can discuss whatever your queries. Okay. So why EPT matters? One thing is it's a challenge. Generally, because diagnosis is a challenge, and other issue is generally we think there's from all the TB cases, 15 to 20% of TB cases are EPTB in low incidence settings. So we are low incidence because less than 100 per 100,000 cases, if there's that is the case load, then we incidence we say it as a low burden country, low incidence country. So we are like that. But high incidence and HIV prevalence countries, the EPTB becomes higher, but still in HIV patients, most common one is pulmonary TB. Then it's always, as I said earlier, it's mostly diagnostic dilemma because these are bacillary disease because the bacterial load is not that great. So the detecting through FB smears, cultures, or gene expert testing will be sometimes very difficult. And confirming your diagnosis is difficult. And also, the TB can like mimic many diseases like, TB, sarcoidosis, so on. Similar presentations can be there. And also, because of these diagnostic difficulties, there are delays in diagnosis that leads to increased morbidity and mortality. So there are management issues also. You have to decide how long should I give anti-TB, and also what are the indications to give steroids. So those issues are there, and some of the EPTB can be actually like quite devastating consequences like CNS TB, TB in the eye, so on, even spine. So this is an important disease category. So we will discuss regarding the basic approaches to EPTB, and I want to update you. There's a new EPTB guideline available, so very recently published. So it is an extensive guideline. So whatever the disease you want to search, you can get all the information necessary for that management through that guideline published by the NPCCD. So these are the case load of EPTB. So you can see Colombo, Gampaha are high TB burden districts. So they have EPTB also. And so percentage wise, so there are these are the respiratory tuberculosis and nervous system, other organs. So what common extrapulmonary ones are the pleural effusions and the TB lymph nodes. So this is how the spectrum goes. So lymphatic TB is much more common, EPTB if you take. Lymphatic TB is more common than pleural, and pleural next one is bone and joint, and genitourinary, then CNS, that is meningitis or tuberculosis, then pericardial, and disseminated TB is even less, and then abdominal and other. We will try to focus on these and discuss regarding others as well. Lymph node TB, pleural TB, CNS TB. So lymph node TB, as I said, is the most common EPTB, and CNS TB, as I said, is a critical disease. 1 minute. Okay. Then bone and joint TB, also known as Pott's disease. So in the very first slide I showed, I said mummies also had evidence of TB. That was initial one, was a Pott's disease, where the TB spine has destroyed the spine, and
Excuse me,
there is
madam.
yeah.
Yeah, can I ask more question, madam? Regarding this.
Yes.
Madam, what's the reason behind that CNS TB is fatal rather than other TB recorded so far?
Okay, so that's an important question, because one thing is, the process. Now, CNS TB, if you don't treat early enough, what will happen? The TB, causes lot of inflammation and then fibrosis. Okay, so these things but there will be fibrinous deposits. Even in CNS TB, we get this basal meningitis, fibrinous deposits, and they can develop hydrocephalus, obstructive hydrocephalus, and so on. So lot of cerebral SOS, tuberculomas, they can develop sometimes. So the whatever the inside the brain, pressure can go up. So those are fatal. Okay. So, and they can affect the nerves also, basal meninges and a lot of nerve palsies. So it is because it's affecting a critical organ. Okay, so because even bacterial meningitis is also, if you are not treated, it's fatal. No. So similarly, this is also fatal, because that side, lot of whatever the immune cells from our body can't reach. No. So if you without drugs, most of these cases are fatal. So how do you diagnose?
Yeah,
Yes.
that's sorry, madam. That lymph node TB, madam, how we can identify the ultrasounds? Are there any differential findings in the ultrasound rather than the reactive lymph nodes?
That's a good question. Generally, the radiologists are very good at differentiating these because reactive nodes generally have what we call as a preserved fatty hilum. And also in the TB lymph nodes, generally they will have central necrosis. Even in the CT scans or the ultrasound, you can see those images if you look. There's central part is more liquid. So that is more typical of TB rather than any other cause. And they are also not reactive. And
Yeah,
then,
madam. You mean that
yes.
abscess formations or like a liquid forming in the lymph nodes in center? Hilum is, yeah, it's fine. It's a hypoechoic. You can see the whitish. That means in the peripheries you
Fatty
can see
hilum
liquid.
is preserved in the ultrasound in the reactive nodes. It is not
Yeah.
present in the TB nodes, and generally, you know, matted lymph nodes mean consistency. And in the ultrasound, central necrosis is one of the features of TB. I am not very good at this imaging. I am not expert on this field, but what I know is generally they can say this whether these are suspicious of tuberculosis by looking at the lymph nodes, ultrasound or CT.
Thank you.
Okay. So if you look at the diagnostic principles regarding extrapulmonary TB, of course, you have to look at the risk factors like HIV, immunosuppression, contact history, persistent symptoms. You need a high index of suspicion. Like joint TB, sometimes pericardial TB, abdominal TB can take like even months to diagnose because their symptoms are very vague. Then, so how do you test? So gold standard is you have to do some kind of try to get some tissue. Maybe it's from or the cell sample. So you can do aspiration, like you can do the lymph node aspiration, pleural aspiration if there's abscess, like a cold abscess and so on. We can try to do aspiration, and you can do biopsy also, like lymph nodes, pleural biopsy, sometimes synovium biopsy in the joints, bones, like that. And you can you must send for histology, and in the same request you have to ask your surgical colleagues to send for AFB staining, culture, TB culture, and molecular testing. That is your gene expert testing. So molecular testing is crucial because, as I said earlier, these are porcibacillary diseases. So very few bacilli are there. So this is more sensitive, and rather than trying to get a FB smear in a pleural effusion, if you do a molecular testing, it's more likely to be positive. And also it's faster. The WHO recommends as the initial test on appropriate samples. One very important thing you should never forget is CSF. You must send CSF for gene export or expert MTB testing, because that might be the only clue. Sometimes very difficult to differentiate between partially treated bacterial meningitis and TB meningitis. So you must send. Then you can send, say for molecular testing in lymph node aspirate, also pleural fluid biopsies, or whatever the other sterile fluids or tissues you take. So as I said, that will also give additional information regarding rifampicin resistance. And the other important thing is, as I said earlier, these are porcibacillary diseases. So even if these molecular tests are negative, that does not tell that this is not TB. So culture remains vital. Culture generally takes a longer time, 2 to 8 weeks. Liquid culture is faster. Then smear microscopy, EPTB, of course, it is low sensitivity, less than 20% in lymph nodes or pleural fluid, less than 10% in CSF. Still, it is useful in positive. So, if you have enough samples, now don't send samples for AFB staining rather than send for gene expert and TB culture, because it will be a waste. You have very little sample. No? Other thing is ADA. I have mentioned regarding this earlier also. This test is very useful in pleural and pericardial fluid, as well as, although not mentioned here, ascitic fluid, like TB peritonitis. So you have to interpret it in clinical context. Then for extrapulmonary TB, as you asked that question, imaging is very, very helpful. So it can be ultrasound, it can be CT, or even MRI, like if you have a tuberculoma or something. So these tests help you to localize the disease and also guide sampling, and also assess any complications like spinal cord compression, hydrocephalus, and all that. But they are not diagnostic alone. But with the combination of other testing, we can most of the time we can come to a diagnosis. Few words regarding lymph node TB. Generally, they present as painless matted cervical or supraclavicular nodes are the common ones, but they can have axillary and other inguinal lymph nodes also can be there. And you can fluctuate, and sometimes you can see a sinus formation. And most, I think you know, there is condition where the scrofuloderma, where the lymph nodes erode into the skin and there's like sinus formation around the neck. That was a common thing in the past. So how do you diagnose? You should find needle aspiration first time, and you can do the cytology, AFB, gene expert, and culture. Then you can do a excisional biopsy if in doubt, especially if the cytology is not typical, because it will give a more confident, like more reliable histological evidence, as well as other important thing is you have to always remember the differential diagnosis of lymphoma or metastatic lymph node deposits coexisting with TB. So this is not an unknown thing. This can happen because if you have a lymphoma, your immunity goes down, and you can your immunity goes down, and TB can be reactivated. And also the other thing is malignancy. It's so common, like in from what you call the
Yeah, madam, excuse me.
yes.
Madam,
Sorry,
regarding
yeah.
that, regarding that lymph node elevations, madam, the lymph nodes in the cervical area, can we do the biopsy and do the culture from that lymph nodes? Can we get positive results from that cervical lymph nodes biopsies on TB patients?
Yeah, you can do initially FNAC, and also then if it is not conclusive, you can go for lymph node biopsy, and the biopsy is especially helpful if you are having a differential diagnosis like lymphoma or metastatic deposits. Also, if you are querying like maybe hematological malignancy, that possibilities are also there. The excision biopsy is useful. Only thing you have to keep in mind is when you do a excision biopsy, sometimes these wounds will not heal. So that problem is there, but of course that is not a reason not to do a biopsy. If it is indicated, you have to do the biopsy.
Madam, are there
But
any
first,
specific? Madam, sorry, travel you. Are there any specific reason to get cervical, even cervical lymph nodes other than other areas the body get
That question was asked recently. Yes, good question. I was that was asked recently, and it was thought that most likely, I don't know regarding research or anything, but this is the reason most of us could think, that is because most of the infections happen through the lungs, no, initial infection. So the draining lymph nodes are mostly cervical and axillary, no. So whatever the infection, most commonly must have spread to lymph nodes and axillary lymph nodes, in the cervical lymph nodes and axillary lymph nodes, and has been dormant there. So the reactivation is most likely to occur in those areas where the original infection. If you remember my slides earlier, I said earlier, after the primary infection, sometime there can be a bacteremia and spread of the bacilli to the all organs where they lie dormant. So because the infection mostly happens in the lung, initial infection, so most likely the draining lymph nodes are cervical most of the time. So most likely the bacilli are dormant in the cervical lymph nodes and can get reactivated. So that may be the reason why the cervical lymph nodes are affected more. Then it is important to avoid empirical treatment without microbiological or histological confirmation, because there are a lot of differential diagnosis, and especially in pediatric cases. And management, generally we give 6 months of treatment to lymph node TB, but lymph node TB treatment is difficult because they can have so what the literature says is, when you start on anti-TB drugs, the lymph nodes might reduce and resolve. Sometimes lymph nodes will persist at the same time even with the treatment. Sometimes they can have a paradoxical reaction and then develop lymph nodes everywhere. So these complications can happen in lymph node TB. So that is generally what we do for lymph node TB. Any questions regarding lymph node TB?
Yeah, then regarding lymph node TB, madam, I am attached to ICU.
Yes.
We are seeing patients with intensive TB. Recently, we had three patients within last 3 4 months. So then one of our nursing staff, she developed something left side supraclavicular lymph node enlargement.
Yes.
So she's worrying about the malignancy or some bowel malignancy also can cause it because it was just not.
Yeah.
Yeah. Then she underwent a biopsy and it came as TB positive. Now she is on FDC.
Yes.
Then can it be due to she is exposed to that intensive TB patients when they are doing the nursing care? So is it can it get it from the intensive TB patients or those things?
No, that's a good question, important question. So, generally, like EPTB will not cause cause a transmission to other people. But as I said earlier, certain conditions, like if you open into that cavity, like a thoracotomy in a patient with TB empyema, then there might be infectious bacilli there, and you can if you inhale, you can get that. And these people who do like what is called JMO's office, where they do a lot of opening into cavities, body cavities, so that risk is there in those cases. Generally, EPTB, now what kind of procedures was she involved in? Resuscitations.
Yeah, intensive TB patients underwent a colostomy for the TB
Oh.
bowel obstruction, and so she involved in the dressing for the colostomy own dressing. The bowel is a decent TB patient, young patient around 25 years.
Oh, is that he didn't have a concurrent respiratory TB, lung TB.
No, lungs are normal. She's a chest
Okay.
X-ray normal.
Okay,
And bowel also normal.
my answer is unlikely. She must have had that earlier, because it's very unlikely to happen, that infection happening within very short time and developing into lymph node TB is unusual. That is what I think. That is what is the evidence also same. So generally, EPTB will not cause a infection other than if you open into those body cavities where the cavity can have the TB bacilli. So colonoscopy, these are very low risk procedures because what you have to know is the procedures that cause aerosol generation are the ones that cause the increased risk. So aerosol generating conditions, the highest ones will come this thoracotomy, opening into thoracic cavity, because patient is breathing ozone, so whatever it is there, that is one aerosol generating condition highly. And the other one is BAL, bronchoalveolar lavage, and bronchoscopy, because patient coughs a lot. And the other one is like liver nebulization, they have risk there. So this nurse must have been exposed, because all of us are exposed now in medical wards and all, even in to a pulmonary TB patient, most likely in the past. So unlikely for that, very unusual for that to relate directly to the nurse's infection, I think.
Thank you, madam.
Okay. Then pleural TB, few words. So presentation, generally unilateral pleural effusion, fever, loss of appetite, loss of weight. Sometimes pleuritic pain can be there. And diagnosis, you have to do the pleural fluid aspiration. So you generally send for biochemistry, protein, LDH, glucose, and also cell count to see whether it is lymphocytic, and cytology to exclude malignancy. So if it is a lymphocytic exudative effusion and ADA cutoff is more than 40, that is strongly suggestive of TB. So that is the most common scenario. But the other condition you can have is a TB empyema. So TB pleural effusions are like posibacillary. That's mostly immune reaction to, causing the effusion, and there's some bacilli are there. But in TB empyema, actually the TB pleural space is infected with TB bacillus, and you will see pus. So these are two different conditions, but both are pleural TB. So, so you can, we discussed earlier, you can do the rapid diagnostic test, molecular testing, and sensitivity is around 16 to 50%, but highly specific. So if it becomes positive in a effusion, you can be you can confirm the diagnosis of microbiologically confirmed tuberculous pleural effusion. So FB culture has a lower yield, and sometimes you, if it is a difficult case and the investigations don't tally, we will proceed with the pleural biopsy. Generally, we do medical thoracoscopy and do the biopsy, or refer for video assisted thoracoscopy by surgeons. So those specimens we can send for all the investigations, including histology, AFB staining, gene expert culture. As I said earlier, those microbiological testing should be sent in normal saline. So management is generally standard 6 months regime, and even the large effusions will resolve. So most of the time, if your diagnosis is TB pleural effusion, you don't need to put a IC tube and drain it. Most of the time, it will resolve on its own only with the anti-TB drugs. Very rarely, earlier days, long time back, we used to give steroids, but that is not very much practice now. Anything to ask about pleural TB? Okay, then we'll proceed because the time also running fast. So nervous system TB, you can have meningeal TB and tuberculomas. So presentations, as you know, subacute headache, fever, features of meningism like neck stiffness, altered consciousness, cranial nerve palsy, seizures. So this is a medical emergency. If you suspect TB meningitis, you will start empirical treatment. So diagnosis, urgent, there's no contraindication. So CSF, classical one is high protein, very low glucose and lymphocytic predominant, but it can be neutrophilic in the early on. And as we discussed, we have to do the gene expert testing. And culture also, if there's enough fluid, you can send for culture. ADA is not reliable in CSF, but if it is done, sometimes we use it. If it is like more than 10, it might be significant, but you don't use regularly send ADA in CSF. Better to the thing you must send is gene expert or expert MTB RIF. Imaging also essential, so you might see basal meningeal enhancement, hydrocephalus, sometimes infarcts, tuberculosis, and so on. So if they are not initially negative, but still the suspicion is there, you can repeat the LP, especially if you start treatment as a bacterial meningitis and patient is not improving. You can, of course, repeat the LP in about 1 week's time and see. And sometimes you diagnose tuberculosis meningitis like that. Start immediately if high suspicion, even before all the results, after sending the CSF samples. And management, you give anti-TB. So generally we give more than 1 year. So intensive phase 2 months and continuation phase at least 10 months. And corticosteroids are a must because, as I said earlier, this will cause a lot of inflammation and later on fibrosis, leading to a lot of complications. So you have to give adjunctive steroids, and like you have to continue it for about 1 month and then taper off. The new guidelines suggest initial IV therapy of dexamethasone, if possible, very high dose. So you can refer the dosing in the newer guidelines. If it is not available, of course, you can give prednisolone or the equivalent other drugs. So the complications can be hydrocephalus, hyponatremia, seizures, raised ICP. Those are the complications. So that is the reason for the deaths. Few words about bone and joint TB. So they present with back pain, stiffness, sometimes deformity, and sometimes can present with cold abscess. You know, the spinal TB infection spreads to the pelvic cavity and can be present as a cold abscess in the pelvic area. And diagnosis is imaging. You generally MRI is necessary, where you see the vertebral body destruction with space narrowing. Wherever possible, you have to do the biopsy and send for the investigations we have said. And sometimes it is difficult to differentiate between pyogenic infection and so on. Generally, in our practice, we give for about 12 months of anti-TB for spine TB as well. So steroids not essential in all cases, but if there's spinal cord compression, we can start on steroids. If surgery is indicated in neurosurgical deficit is there, and it's always important to take the opinion of the orthopedic and neurosurgical input, because like from our part as a chest physician or the respiratory physician, I can't decide alone on these patients. So it's always a multidisciplinary management. Even for CNS TB, it is like that. So what about the other joint TB? Uh, Peripheral joint TB also sometimes we tend to extend, so 6 to 9 months of anti-TB treatment. So key treatment considerations for EPTB. So generally standard HRSD treatment, initial intensive phase with continuation phase HR. Duration, lymph nodes and pleural 6 months, CNS 9 to 12 months, bone 9 joints 6 months, often sufficient, but may consider 9 to 12 months. And disseminated or miliary TB, generally we give longer regime, especially if the CNS is involved. And corticosteroids, steroids when to give, as I said earlier, CNS TB definitely, spinal TB with spinal cord compression you should consider, and also in pericardial TB. Those are definitive indications for steroids. Maybe severe pleural TB earlier we have used, but not routinely for lymph node or bone joint TB. And we need to monitor for all the drug related side effects. This is true for pulmonary TB as well as EPTB. So as general practitioners, you also, when you get these patients who are on follow up, you have to, or they might come to you with the side effects saying that their urine is dark, or they are developing a rash, they are having oral ulcer, so they are having nausea, vomiting. So you might get the common side effects of anti-TB drugs, and you should know what to do. And in ethambutol containing regimes, of course, when you are giving ethambutol, always think about possibility of optic neuritis if they are having uh, any visual disturbances. Sorry. Dots we discuss, somebody has to supervise, or as we said, telemedicine via video conferencing, you can monitor the patient. So what are the take home messages of TB? You have to suspect EPTB, and you have to get tissue or fluid for biopsy aspiration. And yeah, uh, expert gene expert or expert MTB RIF ultra specially is very useful for samples because it has a much more higher sensitivity, and longer duration for CNS TB, and steroids for indicated ones. And of course, as I said earlier, in BCCD guidelines available, and of course these patients should be managed as uh, multidisciplinary management is needed in most of the EPTB patients, because it is not our area, because it's not lungs and the pleura. Most of the EPTB are in the other sites. So we need help of the orthopedic surgeons, neurosurgeons, rheumatologists, and so on when we are managing. And ideally, in the ideal world, not only us, they also should follow these patients up for the clinical improvement, because in the what happens in the chest clinic or by seeing by the respiratory physician, it is mainly to issue the drugs and see for the side effects and monitor the patient generally. But organ specific things, the other specialists should look after. So this was not mentioned in this presentation, but peritoneal TB also very important. So if you suspect peritoneal TB, if there's ascites, you can of course aspirate and send for investigations, including ADA. So you have to check for the SAG, no? Serum acidic albumin gradient, and also do the ADA and gene expert and TB culture. And if necessary, we'll ask the surgeons to do laparoscopy and laparoscopic biopsy. So, although not very common, it is also one important presentation of TB in the EPTB. Okay. So, any questions regarding EPTB? Is that okay?
Madam, can I ask a general question?
Yes.
Now, regarding the anti-TB treatment, now we have frequently seen senior consultants, they're using the drugs like linezolid and levofloxacin frequently for the respiratory infections. Is there a policy in respect of the TB treatment, and are there any restrictions you all have put to? I just want to know about that.
Sector health. You should see my slides? Me? Can you hear me?
Yes.
Yes, madam, clear.
Yes, can hear, madam.
Okay.
Yes, ma'am, can hear.
All right. The hello.
Can see the screen, madam.
Can no? Okay. See no, so I'll proceed. Okay. So they are going to discuss TB in special circumstances, some of the circumstances. So that special circumstances can be physiological or pathological. So what are the physiological ones? Childhood, pregnancy, newborn and elderly. Pathological ones, renal TB, diabetes, liver disease, HIV, AIDS. So I'm going to briefly discuss regarding these because of the time constraints. So childhood tuberculosis is very, very important because as you know, their immunity is low, and when they are exposed, there's a higher risk of getting disseminated TB and TB meningitis. So that is why we give the immunization with BCG vaccine to prevent those devastating consequences of TB like disseminated TB and TB meningitis. When you are considering childhood TB, only a small proportion will have any kind of positivity of your microbiological test, and they can get higher number of EPTB. You need high degree of suspicion, and as I said earlier, when you are suspecting pulmonary TB in a child, most if they are younger than 3 or so and can't produce any sputum, you will have to do gastric aspirates. And sometimes now the newer testing with fecal testing for gene expert are also there. So when considering the TB, so this is the comparison. This is more like in younger patients, they get this kind of manifestations, and in the more older patients, it's more like looks like more post primary appearance. Pitfalls, clinical manifestation in pediatric TB may be non-specific and high degree of suspicion is necessary. It is more difficult to diagnose in children, and undiagnosed or untreated TB in a child is potentially very serious. As I said, more likely to develop severe and disseminated disease. So this is very important to remember. The diagnosis of TB in a child is a sentinel event. So if you diagnose TB in a child, because they have very limited contact, you have to find who is the positive contact in. It's very, very important. And also this issue regarding their parents not wishing for the or they want to avoid the drugs or the investigation, especially gastric aspirates. So those issues are there. Sorry. Oh. Somehow I am missing one slide now. Okay, I will just tell those. The other issues are regarding ethambutol. You know, there's worry about visual damage, and the child might not be able to say whether there's any alteration in vision when you are giving ethambutol containing regimes, but that has been proven against. So most of the studies have shown that even in a very young patients like 6 months old, we can give ethambutol, but in common practice we give for a little bit all the children, but especially if there's more extensive disease and if the background high INH resistance and high HIV prevalence, then you must incorporate ethambutol. So as I showed earlier, childhood TB and congenital TB in infancy may present with miliary shadows, and adults with presentation more like a smear positive post-primary TB. So you can see the small dots. I don't think it's a very good film, but some consolidative changes as well as some miliary mottling are there. One thing is missing this somehow. I missed one slide. So what is very important is it is WHO thinks that we are missing many childhood TB cases. Can you answer me what kind of patients do you should suspect as having TB in childhood? When would you think?
Socioeconomic group or
Yeah, economic group, poor, yes. What kind of symptoms?
Growth retardation.
Failure to try growth.
Very important, very good. And that is one of the key things you have to observe, because as GPs, you will see a lot of patients in the childhood, where children also as patients. So always it is better to go through their development record and see whether what is their weight, and if there's chronic failure to thrive or recent weight loss with respiratory symptoms, or those things are the important things when you the suspicion of TB should come to your mind. And the other thing is failure to thrive. Sometimes they become inactive. Some I have seen children who have been become little bit lethargic. They are not doing their work. Probably they are talking and eating and all that, but maybe the background loss of weight, loss of appetite, but very lethargic, withdrawn like. Sometimes they might have overt features of TB, meningitis, and all that. Failure to thrive, inactivity. Of course, there are symptoms like cough, persistent cough. Sometimes it can present like asthma also. Asthma, if your patient is not responding, you think as asthma, but not responding to treatment, of course, you have to think about treating any other differential diagnosis you have to consider, and TB is one important thing. So, failure to thrive and lymph node TB is also fairly common in children, so you have to do the diagnostic workup. Um, so always should have a very high suspicion, and also when you are examining, see whether the BCG mark is there, and if they are younger, less than 1 year, and having absent BCG scar, or it is not documented in the CHDR, you can refer for repeat uh, BCG vaccination as well. So those are the mainly childhood TB. So there's childhood TB guideline is published, and it is available in the website. So that is a very good guideline, covers all the aspects. So you should go through that. Then tuberculosis in pregnancy. There's no difference in susceptibility to TB or disease goes in pregnant versus pregnant women unless immunosuppression coexists. And so the issues are like constitutional symptoms may be attributed to pregnancy, and their physiological changes like with the ESR can come like go up even without any TB. Sometimes it's a difficult thing that is referred to us, and weight loss also may be difficult to interpret. So this is a rough guide how much weight should be there gain during each trimester. So healthy person we estimate at least 11 to 16 kilograms. But if this weight gain is not there and high ESR, maybe cough, you have to think about TB. uh, and I think you have seen the pregnancy record that is maintained by the prenatal clinics. So there's a graph where they monitor the weight gain, and if they are losing weight, if we refer to that, we can clearly see if they are not gaining weight. So that is a useful document to refer. Then avoid x-rays in pregnancy. Of course, if you are clinical suspicion of TB, you have to do a x-ray with the lead cover. So these studies have shown that it's not significant exposure uh, to the fetus. Like it says, if you say chest, 2 views, estimated exposure is this much. So if you have to required some fetal effect cumulative dose to achieve the cumulative dose for some problem to the fetus, you have to do more than 70,000 chest x-rays on that person. So to affect the fetus, so sometimes background radiation may be much more than the doing a single chest x-ray. So this is an important thing because there are females coming at late pregnancy, sometimes diagnosed with positive TB, could have been diagnosed much earlier if they have had a chest x-ray done, and sometimes maternal deaths also related to TB undiagnosed. So this is something you have to remember. So you will need your consultant's signature for this x-ray if you are doing it in the government sector, but in the private sector you can request the lead cover. So or you can refer to the chest clinic or the chest physician to get this test done, because it is very, very important to exclude the TB in pregnancy. So basic treatments are the same. Streptomycin is avoided, as you know. So rifampicin can interact, and so generally vitamin K is given to the babies if the mother is on this one, ATT. So what about lactation? Breastfeeding can be continued unless TB, HIV co-infection, and they should receive the full course of anti-TB. All first-line anti-TB drugs are compatible with breastfeeding. Mothers are advised to wear a mask during breastfeeding and avoid coughing onto the child's face, and should breastfeed in adequately ventilated place and minimize sharing common breathing space with the infant if it is possible. Then tuberculosis in the newborn. Perinatal and neonatal tuberculosis has a very high mortality. So tuberculous basilemia during pregnancy may result in the infection of the placenta and the maternal genital tract, and so can get the baby can get through transplacental route or infected amniotic fluid ingestion and aspiration, and also the possibility of airborne inoculation from close contacts after the birth. So primary complex, if you swallow the infected amniotic fluid, your primary complex will be in the gut. So TB in the newborn, non-specific. So usually multiple organ involvement. Commonly symptoms are in the second and third week of life. They may be acutely ill, fever, lethargy, irritability, respiratory distress, hepatosplenomegaly, lymphadenopathy, failure to thrive. So you have to investigate X-rays, direct smear, as we said. Most important one is, although not mentioned here, is the the whole slide. That is why it is not coming up. So there's a congenital tuberculosis also there. If it is coming from the birth, the child might of hepatosplenomegaly, splenomegaly, abdominal distension, lymphadenopathy, meningitis, septicemia, and lung involvement. So those is a serious condition, congenital TB. So you have to know about the features of congenital TB as well. And this is not a unheard of condition, because we have diagnosed patients in LRH, newborn babies with TB, sometimes with congenital TB in the very recent past as well. So what to do about the newborn? This is in the guideline. So what you have to know is, if the mother is smear negative and child is well, you can give the BCG at birth. But if the mother is smear positive, child should be examined for any active TB or congenital TB evidence. So here, confirm PDB in mother during the pregnancy. Check mother's status, smear negative. You have to examine for any evidence of congenital TB. If it is there, you have to start anti-TB. If there's no congenital TB and child is well, you can give the BCG vaccine. No isoniazid prophylaxis is needed. What about smear positive mother? Congenital TB evidence is present. Of course, you have to start on ATT. If there's no congenital TB, you start on isoniazid for 3 months, not give BCG, and review at 3 months. And at 3 months, if the child is well, we do the MANTU test. And if it is positive, you complete the isoniazid prophylaxis for 6 months, and no BCG is needed because already the child is exposed to bacillus. But if the MANTU is negative, child just will be given BCG, and there's no need to continue the IPT because the child is not having TB infection. Then, if there's any evidence of congenital TB at any point, you have to give anti-TB. This is, you can get it from the guideline. So what is important is, if there's no evidence of, if there's evidence of congenital TB, you don't give BCG, you just treat with anti-TB drugs. If there's no congenital TB, if the mother is negative, you can, and the child is well, you can give the BCG. If the mother is positive, you give some time, you start on INH prophylaxis and review at 3 months to see the child. And if there's no congenital TB, and you do the MANTU at 3 months, and the MANTU positive means already infected, so you just continue the prophylaxis treatment. You don't need to give BCG. But if the MANTU is negative, that means child does not have any bacillus in his body, so you can give the BCG and stop the IPT. Tuberculosis in elderly is important. This is something that we miss because we have more elderly people, like aging population. You can attribute to their symptoms to their old age. So this, when you are seeing patients with chronic cough and all in older patient, constitutional thing, symptoms, always think about TB. Renal disease, they are at increased risk, so 30 times higher risk if they are in like a later stage of CKD, very high risk of getting active TB. And sometimes very difficult because they might have features of uremia that can be the same as of TB, and they are also on immunosuppressive therapy most of the time, and they might also have malnutrition, vitamin D deficiency, hyperparathyroidism, and so on. So they are immunodeficient and all these problems, so they are at higher risk. So they can be insidious onset with fever, anorexia, weight loss, cough, hemoptysis. Lungs are the common site, and extrapulmonary also can happen. And MAN2 can be negative in advanced CKD. So you have to take the MAN2 value positive as 5 millimeters. So you have to think about the interactions, drug interactions, and timing related to hemodialysis and the treatment duration. So generally what we do is we give, if they are in advanced renal disease, far less than 30, we will give the ethambutol and pyrazinamide every other day. But isoniazid and rifampicin doses don't need to be changed. Streptomycin better to avoid. Uh, and there are issues regarding and the benefits of giving post dialysis or pre dialysis. Both issues are there. Generally we don't we generally ask them to take early morning drugs, so we don't specifically try to time it with the dialysis. So this is the treatment. So you must calculate the EGFR, and so if it is less than 50, you have to give ethambutol and pyrazinamide every other day. If they are transplanted and EGFR is okay, you don't need to change the drug regime. So transplant recipients are also a complex. They are on complex immunosuppressive therapy. So you can consider for latent TB treatment in certain cases, especially awaiting transplant or after transplant, after screening. And also rifampicin interacts with steroids, so you have to dose adjust steroids. Latent TB and diabetes. So you have to remember, you will see a lot of diabetic patients in your practice. So they are at 3 to 4 times higher risk of getting TB than the general population. I mean, TB disease than the general population, and they have their symptom severity is more severe TB, and their outcome is also poor. So this is especially if their glycemic control is not up to the standard. So it is your duty to optimize their glycemic control and advice. So if they don't achieve their optimal glycemic control, they are very likely to have a relapse of tuberculosis. Liver. So baseline liver function we have to do, and generally pyrazinamide, isoniazid, rifampicin all can cause liver problems. So if you want to give a liver friendly regime, most of the time we will give ethambutol, quinolone with the aminoglycoside. So there are different regimes you can use. And also you can do the child scoring and decide which treatment. Sometimes, although the issues are there, sometimes they tolerate anti-TB fairly well. HIV infection, few words. It's called double trouble. So there's 50% lifetime risk of TB if they are latently infected. Normally the risk is 10%. That what it's increases to 50% in co-infection. It's one of the most important life-threatening infection associated with HIV. Um, so you can see how it has been uh, uh, with the AIDS cases has uh, gone up with the HIV epidemic. But when you start on treatment, the cases of pulmonary and disseminated treatment has gone down with the ART treatment. TB also still the pulmonary TB is the most commonest, but they get more higher chance of EPTB and disseminated TB. The clinical picture, if it is their CD4 count is high, they will resemble post-primary TB. But if it is low, they will have a more like a primary TB and maybe miliary changes. So this is like first one is a post-pulmonary like appearance in a patient with higher CD4 count, and the second one is a miliary dissemination. Here, of course, you can see the miliary TB like small nodules all over the lung fields, randomly distributed, both lungs. So that's a classic miliary TB appearance. So always it is very important to look for drug-resistant TB, doing cultures and expert. And priorities to treat TB. This you start on anti-TB drugs and uh, try to start ART as soon as possible if it's possible. Within now, of course, earlier the better. So within 2 weeks or so, we try to start, but always you have to keep in mind the reactions like iris, immune reconstitution syndrome. So if the CD4 counts is low, should be commenced within 2 weeks. So this is, of course, you can discuss with the venerologist and decide what is the best plan. So iris, the paradoxical exacerbation of symptoms, signs, and radiographic manifestations of TB, because when you give ART, their immunity increases and they develop reactions against the TB bacilli. So it's a balance. You have to, if you give early ART, there's a risk of iris, but if you defer ART, because you are afraid of iris, you might get HIV disease progression and poor outcome. Manifestations of HIV patients, large collections, TB, and skin manifestations, and the drainage. This I'm not going to go into detail. You can read about this. So it is treatment regimes are as same as HIV non-infected patients. What's important, they can get more side effects. Drug interactions are a problem, and high recurrences, and also high case fatality ratios. Generally, what we do is we give the normal anti-TB drugs, and the venerologist adjusts the ART according to whatever the interactions. They adjust their drugs. So generally, what we issue is the normal anti-TB drug regimes. So this is very important to remember. You have to screen. So this is a two-way screening is there. All HIV patients are screened for TB. They will refer to us to screen for active and latent TB, and all the TB patients, they will have a HIV test. All the TB diagnosis patients. So there's two-way screening is there. It's well established. And also sometimes cold-term prophylaxis is also important. And So you need to give isoniazid prophylaxis. We'll come to that in the latent TB, but you have to keep in mind that tuberculin skin test, 1-2 positivity is taken at more or equal to 5 millimeters, not 10 millimeters as in others. So that is regarding that one. Any questions? HIV, TB, or children with TB? Okay, we'll proceed to the next one then. See the screen. Can someone answer, please?
No, madam, can't see it.
Can't it say? Okay, just 1 second. Directions in latent TB. Can you see?
Now can see.
Yeah.
Now can see, madam.
Can see, madam.
Okay. Okay, so this is a one of the lectures I have done recently. I will go through it so that you have an idea about TB management in Sri Lanka as well. If you have any questions, you can ask. So the of tuberculosis is high around the world. It's a significant killer. So, and I also discussed regarding NTB strategies, and because WHO tries to eliminate TB by 2035. So, in the lower down image, you can see regarding our milestones by 2025. I said TB incidence rate we want to reduce by 90%. And this was also around 90. This was like 0% we want to achieve. But actually, we have come down only by incidence rate only to 8.3%. Number of TB deaths 23. Sorry, this is what was expected at 2025. Okay, there were milestones. So these are not the 2025 35 milestone. 2025. By 2025 we wanted to come somewhere here. Wait. Yeah, somewhere here. These the goals. We are far behind. 8.3 reduction only in incident rate. TB deaths only 23% reduction, and also we want to reduce the catastrophic cost to 0, but also that is also only 49%. And mind you, most of this good data comes from developed and developed world, and most of the in the countries and poor countries are not doing even this much. They have not achieved. So I said, about the local burden, we have high death rate, but incidence is less. If you want to eliminate this TB preventive treatment or latent TB treatment, or treat in the TB infection state, is very important. And it is if you treat latent TB properly, the risk of developing active TB will reduce by 60 to 90%. That is a significant reduction, and it is a cost-effective intervention to reduce the TB deaths. And it comes under the Pillar 1 and Pillar 2 of WHO policies. So this is the important. What is the importance of TB infection? They have done this analyze the prospect of different strategies. So only if you reduce the risk factors or the prevent infection or only treat the TB disease, you will not achieve the NTB strategies. But if you treat the TB infection, that is the reservoir of infection. I said 1/4 of the world's population is infected with TB. So if we treat that reservoir, then it might be possible to achieve these NTB targets. So we have to treat the active TB as well as the latent or the TB infection in the general population. This is a patient who is infected with TB bacteria at some point in their life, but no signs of active TB or symptoms of TB, and they will not spread the disease for TB to anyone. But without treatment, there's approximately 10% of these people will progress into developing TB disease. The highest risk is in first 2 years, that is 5%, and it will be 0.1% year thereafter. Uh, so without treatment, this can advance to TB disease, especially if they are having any immunocompromised state like HIV infection, anti-cancer therapy, dialysis. So that the risks we have discussed. WHO has this two-pronged policy based on TB burden and income. So we as a low burden TB country, just give me 1 second. Okay, there's a call. Hello. Oh. අනේ මට ඔය වනව වලින් වගේ කතා කරන්න. Okay. හරි. Okay. Okay, sorry for that. So earlier what we practice is we have treated the child contacts less than 5 years and positive patients with latent TB treatment. That is what, as like earlier, that is what we did. But now, because we are a low burden country, WHO has recommended for us to expand our latent TB treatment. So we have included these groups. So we now we have started treating all the contacts, child and adult contacts of pulmonary TB. And anyway, we were doing, and also we have included transplant patients, silicosis patients, dialysis patients, and patients on specific immunosuppressive treatments like anti-TNF alpha and anti-TNF alpha inhibitors. And also in a next stage, probably we'll be screening all the other risk categories like prisoners, healthcare workers, immigrants, and so on. At this stage yet, but we have started screening the contacts and the high risk groups. So that is the same thing it is mentioned here. So we screen the HIV, TB patients, adults and children, household or close contacts of pulmonary TB, and other risk groups, as I mentioned earlier. Why we do this? As I said earlier, HIV patients have uh, risk of developing is 50% risk of developing active TB, and actually it is 20 to 37 times greater in people living with HIV. TB contacts also at high risk. I will show some data. CKD patients, as we discussed earlier, about 30 times higher risk of developing active TB. Silicosis also has an increased risk, like 30-fold increase. And we said about 3 to 4 rise is increasing. And also smoking, mind you, if you have a heavy smoker, risk of TB is increased 2 to 4 times. So contact tracing and screening for TB in contacts. So if you take the risk is 1 in general population, if you are a close contact in all age groups, like 0 to more than 15, all groups, the risk increases like 20 to 30 fold if you are a close contact, and this risk is much higher in the first 2 years of exposure. So that is the basis of treating these patients, so that we can treat lot of at risk patients with latent TB or TB infection. So it is a very easily identifiable group, and they are at a higher risk, very high risk of getting TB in the next 2 years or so. So that is why we have chosen this household contacts and also non-household close contacts. So what do you do when you want to screen for TB? So step 1 is, of course, you have to exclude active TB. So you do the symptom review for TB cardinal symptoms we have discussed, and we have to investigate for active TB, or the what we call as not active TB, proper term is TB disease. So you can do ESR, chest X-ray, sputum investigations like AFB, gene expert, other nucleic acid amplification test, and other testing. And if they are all negative, sometimes you will have to do even a CT scan in a silicosis patient, let's say, because they have a lot of lung damage. It's very difficult to differentiate. So sometimes the initial tests are negative, you will even do a HRCT to exclude active TB or to detect any active TB evidence. Then if they are all negative, you will go to investigate for latent TB or TB infection. So what are the tests available? We have the MAN2 test, or the two-step MAN2 testing. So as I said earlier, MAN2 of 5 millimeters is taken as positive in HIV, or if they are in immunomodulatory therapy, or if they have evidence of all TB. And the other important tests are IGRA testing, TB Gold and T-Spot. I will discuss them. And the other newer one is available, that is a tuberculosis antigen-based skin test. So, but as I said earlier, they will not accurately differentiate between the latent TB infection or TB disease, and they can't differentiate from reactivation from reinfection, or not not change according to the stages of MTB infection. So MAN2, I think all of you know. So you can help to MAN2 help reading. You can help. The guidelines are available in the our TB guidelines. Will have gives all the information regarding how to read the MAN2. You should be aware how to do it properly. And the other newer thing is two-step MAN2. That is like if you are infected with TB bacillus, but it has been long time back, so your immune system has forgotten that you have got the infection. But if you when you give the first MAN2, there's a boosting effect, and then the immune system will remember. So you repeat the test in few. First test is negative, you repeat after within two to like 1 to 4 weeks. Then it becomes positive, that is called the two-step MAN2 is positive. That shows that patient had a infection in the past. So when the other tests are costly and all, this is a very good test. We can use the two-step MAN2 testing. Then or what do you call, we must have heard about TB. So these are testing. So they assess the interferon gamma release by the T cells. They are specific, not like MAN2 test. They use only specific MTB target antigens, ESAT6 and CFP10. It is more specific than MAN2 testing and not less chance of cross-reacting with BCG and non-TB mycobacteria. But mind you, there are difficulties because you have to transport very quickly. You can't draw the blood and keep it. This is a blood test. Only a few hours, you can within 8 hours T-spot, and quantiferon gold in tube 16 hours. So generally you have to send the patient to the lab and get it done. This is available in the National Research Laboratory and for specific patients, especially CKD patients awaiting transplant. We try to get the, if the MAN2 is negative, we try to get the IGRA as well. Then there are benefits. IGRAs, as I said, BCG and non-TB not reactive. And but it is the sensitivity also diminished by HIV infection. But reagent costs, need to avoid delays, and need for reliable labs and proper storage of kits are concerns in developing world. So the other test I said, new test is tuberculosis antigen-based skin test, TBST. So we use the same kind of specific antigens, but we not measure that reaction in the blood, but we we do it as a skin test, similar to MAN2. We inject this into the skin like MAN2 and measure. So this is a more accurate and reliable test. Now the campaign is trying to implement this also. So it is specific for TB complex. So these are the groups we are treating latent TB treated, people living with HIV and HIV negative close contacts, and the other risk groups. So few words about these circulars are there. So living with HIV, you generally exclude active TB, test with MAN2 and IGRA. If they are positive, you treat for latent TB. But still, if the latent TB investigations are negative, but there are a very advanced immunocompromised state, or there are socio-demographic factors, then we can discuss and start on IGRA treatment. If the child is more than 1 year, we exclude active TB and then start on TPT. Less than 1 year, we don't regularly treat unless they are having HIV plus a contact of PTB as well. Then contacts, we now start at stages we have started less than 5 years long term we have been practicing, then we started 5 to 15 years and more than 50 years group. Then now we are doing into all groups including 15 to 50 years. We exclude active TB and then test for latent TB, and if they are positive we treat with latent TB treatment. So if the child is less than 5 years, you don't need to do MAN2 or IGRA. You can just treat, if there's no active TB, you can just offer latent TB treatment because the benefits are much, much more than the risk of treatment. But in adults and children more than 5 years, of course, we exclude active TB and then test for latent TB, and if they are positive only, we offer the treatment. If the initial latent TB investigations are negative, we will follow them up for 2 years under the area PHI. So because that is the highest risk of period of getting TB reactivation. So dialysis patients also pre-dialysis, ideally before starting dialysis, all CKD patients should be screened for latent TB and started on, if they are positive, you should start on this latent TB treatment. Silicosis also the same. You can see how they look like. And as I said, you might need HRCT as well. And other important thing is TNF alpha inhibitors. You know, this molecule is the one that maintains the granuloma. So in these patients who are planning for like infliximab and so on, for like sometimes for Crohn's disease, seronegative spondyloarthritis and all, then you rule out the active TB and test for latent TB. And if positive, start on TPT. Generally, after giving this latent TB treatment for 1 month, you can consider starting on TNF alpha antagonist. But you have to always closely monitor these patients development of active TB. So the current guidelines does not say to start treatment for non-alpha TNF alpha targeted biologics, but you can of course treat for latent TB and keep a close eye on these patients. Then whoever is awaiting solid organ and hematopoietic transplant patients, both the recipient and the donor, where possible, should be screened for latent TB infection and should be treated. This I won't want to cover because it's an extensive topic by itself. You can refer the latent TB guideline for further details. So what treatment for latent TB you can offer? You know, generally it has been 6 months of isoniazid for most cases. Now we have this 3 months of isoniazid and rifapentine weekly available. So that is also used now. And of course, if you need a shorter duration, earlier we used to use both combination of isoniazid and rifampicin daily. Now we have this isoniazid and rifapentine weekly regime. So generally, this is how it goes. For patients living with HIV, both children and adults, if we want to give prophylaxis, we give 6 months of isoniazid, and also HIV negative close contacts less than 2 years, also 6 months of isoniazid, because rifapentine, it's not proven to be safe in less than 2 years. But this 3 months of weekly isoniazid and rifapentine is the regime recommended for HIV negative close contacts above 2 years, and the other clinical risk groups like transplant patients, dialysis patients, TNF alpha inhibitor patients, and silicosis patients, because it's very easy to use. So it is avoided in less than 2 years: active hepatitis, peripheral neuropathy, pregnant uh, uh, or breastfeeding, and protease inhibitor based antiretroviral therapy. So this is also available in the guideline, which drug regime you can choose in which patient. What is the preferred treatment? So weekly rifampicin plus isoniazid treatment is proven effective in trials. So the evidence is here. And adverse effects are much less. Even in children, this prophylaxis treatment is well tolerated. discussed earlier, isoniazid preventive treatment ranges from 60 to 9%. There are so many studies done. And generally, repeated causes of prophylaxis is not indicated. And generally, drug resistance is also not a major issue that has been studied. There's no major risk of developing drug resistance by giving this tuberculosis prophylaxis treatment. So it can be given in TPT, and generally we recommend 6H. So that is the end of that lecture. So it's effective strategy in TB elimination. Clinicians should be aware about the high risk groups and available investigations, and it will prevent the it will reduce the global TB reservoir. So that is the end of that. So those are the ones that I wanted to discuss. If you want to have any, like, if you have any questions, I can answer if there's any questions.
Yeah, madam, that the
Yeah.
staff who is working in a dialysis unit and long-term period exposed with patients, and so many patients are coming. What
Yeah.
is there any recommendation for that persons?
There's no recommendation, but we know there's TB screening also there. No, we screen like prisons. We screen like what is this elderly homes and all. No, so under those we can screen. Actually, in Nigambo, I have planned to screen the JMO office staff. So similarly, if you discuss with the DCO, District TB Control Officer, and the respiratory physician of the relevant area, you can get a screening done. Especially because it's not in the guidelines, but because we can do the screening using the existing tools, no, like X-ray and the MAN2, maybe even two-step MAN2. It won't add too much cost, and we can do it easily. So that it's not in the recommendation. I said no, only we are strongly recommending the ones that I have discussed, but the next stage will be the healthcare workers and all. That is the stage the other countries are in the Western world. If you go to work in UK or whatever the Western world, they will do a T spot on you, and if it is positive, they will offer you prophylaxis treatment. They will ask whether you will want. So generally what we tell is, we are going back. Those days we just told that we are going back to Sri Lanka. It's TB. We are again going to get exposed, so no, not necessary. Or you can get that treatment. So now, because we are low burden country, it's a good thing we can do it. It's not like, although it's not in the guidelines, like case by case, or the in the that relevant area, we can do those kind of screening tests. You have to contact your DTCO is the best way, or the respiratory physician. Anyone else? Any questions?
Thank you, madam.
Okay. If there's no questions, shall we end? Thank you, everyone for their listening and the questions. And actually, it was a very good discussion, and I think you gained from the lecture. Thank you very much. Okay. Any questions in this one?